Respected seniors, dear colleagues and dear residents, very good morning to all of you. Before starting the today's topic, I would like to just give a brief introduction of our department. So, under the leadership of Dr. B.S. Sharma sir, we are running 3 units in our department. In Unit 1 is comprising of himself, Dr. B.S. Sharma sir, and Dr. Jitendra Verma, Professor, Yogesh Agrawal and Kshitij Agrawal, both are associate professor in Unit 1. And in my unit, that is Unit 2, I have my colleague Dr. Pawan Kumar Jain, he is associate professor with me, and the third unit is run by Dr. Rohin Bhatia. We have 6 seats per year of the MCH residency, and right now we are having 13 senior residents in our department. Our department is heavily equipped with multiple equipments, the latest equipments. We are running 5 theaters per day with all advanced equipments like 3 high-ended microscopes, endoscopic unit, Vitome, 2 neuro navigations. We have intraoperative neuro monitoring, by which we can perform the safe surgery. During surgery, we can observe any kind of damage to the normal brain. And nerve stimulator, we have 2 CUSA. We have electrocorticography. Recently, we have started the epilepsy surgery by using electrocorticography. We have separate neuro ICU and HDU on the 4th floor. We have O-arm. We have 2 high-ended C-arm, intraoperative Doppler, coabulator, microdebrider, and Doro system. So we are comprising of a team of dedicated, trained and experienced faculty, and we have a very good neuroanesthesiologist team. We have 6 neuroanesthetists and 3 DM candidates for neuroanesthesia, and we have an intensivist. We have neuroradiology, neurorehabilitation department, neuropathology department, and we are having trained and specialized paramedical and nursing staffs. In last year, total IPD was above 10,000 and OPD was above 10,000 and IPD patients were around 2,100. Total cases we operated in last 1 year was 1946. That is with average number of 162 per month. We are operating in all kind of brain and spine surgery. Brain surgery mainly consisting of brain tumors, skull-based surgeries, all kind of vascular surgery, pediatric surgery, most of the endoscopic skull-based surgeries, trauma, stroke, epilepsy surgeries. And about the spine surgery, we are operating through the maximum cases we are operating by the microscope and endoscope, with some cases which are indicated for minimally invasive spine surgery. And instrument we are having O-arm with 3D imaging. We are operating on the brachial plexus and peripheral nerve surgeries also. Here you can see the O-arm. For the residents, basically this O-arm is like a mobile CT in operation theater itself. While we start the operating on the patient, we take this O-arm on the operating table, and we take the real-time image, and then these images transfer to the navigation machine. And by looking to the navigation screen, we operate on these patient. We put the implant, so that is a good safety measures. In last 3 years, we have done we have published 13 papers from our department. And last month in February, while taking the exam for MCS resident, we clubbed our exam with the CME. We asked our externals to stay for 1 day, and for the whole day we did the live surgery telecast, which was relayed on the YouTube and which were released on the YouTube. And these are our upcoming future events. Tomorrow we are going to we have invited our one of our colleagues based on the USA. He will talk on the deformity surgery. So our from neurosurgery department and orthopedic department residents will be welcomed, And on this Sunday, on the 17th March, where we are planning for microvascular suturing and skull-based drilling session for the residents of neurosurgery as well as plastic surgery. And we are planning for live surgery demonstration in October 2024 and next exam to be held in April 2025. Recently, in an international conference held at Jaipur, our two residents presented presented a case presentation in the international conference. And recently, in last month, along with the ENT department, there was a workshop on the ear surgery. Our residents also participated in the temporal bone drilling. Now we are presenting the case and hand it over to Anurag.
Good morning everyone again. So the case for today is a 45-year-old patient with severe headache of 1 month duration. So 45-year-old male electrician presented to us with headache of 1 month duration. The first episode of headache was sudden in onset. It was severe, worst at the time of onset. It started early in the morning. It was non-localized holocranial headache, throbbing in nature, for which he had to visit an outside hospital, and he was managed conservatively by IV drugs, which no details are available, and he was discharged. And the pain at that time was not associated with any nausea, no vomiting, no photophobia or phonophobia was there. Subsequently, the headache became episodic, but it used to happen almost every day, though the severity decreased, and it got relieved on taking medications, and he used to consume almost 20 to 25 painkillers in last 1 month, and the pain was such severe that he had to get up in the night and the night sleep got disturbed. There is no history of vomiting, no history of trauma, there is no history of neck stiffness, fever, any visual symptoms, nasal, eye congestion or lacrimation, loss of consciousness or seizure, no sensory involvement or motor weakness, no change in intensity of headache with change in posture, and no association with any particular activity. The patient also complains that he never had any similar complaints in past. No history of hypertension, no history of diabetes mellitus, no history of tuberculosis, no asthma, no COPD, stroke or coronary artery disease. There is nothing significant in family history. The patient is married, having 2 children. He is non-smoker, non-alcoholic, not consuming any recreational drugs. He is vegetarian by diet and sleep pattern is disturbed. He is not allergic to any drugs and he is not consuming any blood thinners. So, summary is a 45-year-old male with normal habits presented to us with severe sudden headache of 1 month duration, worst at onset, which required a hospital visit, and subsequently the headache became episodic with decreased intensity, and he took almost 20 to 25 pills the night, and the headache used to disturb his night sleep. But he didn't have any history of trauma and no history of blood thinner use was there. So can anyone tell me what are the possibilities of such case? So headaches can broadly be classified into 3 categories. It could be either a primary cause, a secondary cause or miscellaneous cause. So primary cause is migraine, cluster headache or tension headache. Secondary causes are due to some reasons like vascular region or intracranial space occupying lesions or infections or glaucoma. And miscellaneous causes are exertional headache, coital headache or cough headache. The patient was conscious, cooperative, well oriented to time, place and person. No pallor, icterus, cyanosis, clubbing or lymphadenopathy was present. Vitally, the patient was afebrile. His pulse rate was 82 beats per minute in right radial artery with normal rate and rhythm. No radioradial or radiofemoral delay. Blood pressure was 128 by 86 mmHg in right arm in supine position, and body mass index was 24.6 kilograms per meter square. Systemic examination including respiratory, cardiovascular and per abdomen examination were within normal limits. The higher mental function status was normal. Speech was normal. Cranial nerves including the fundus was normal. No cerebellar signs were present and no signs of meningeal irritation was there. In bilateral upper limbs, the bulk and tone was normal, and power at shoulder, elbow, wrist, and bilateral upper hand grip was 100%. In bilateral lower limbs, the bulk, tone were normal, and power at hip, knee, ankle, and external hallucis longus was normal. The deep tendon reflexes, that includes biceps, triceps, supinator jerk, and knee jerk and ankle jerk were normal. And superficial reflexes like abdominal and Babinski were normal. On sensory examination, the sensation to pain, temperature, and light touch was normal. Crude touch, 2-point discrimination, sense of joint position sense, passive movement and vibration in bilateral upper limb, bilateral lower limbs and upper limbs were normal, and gait was also normal. So, on basis of history, this is a 45-year-old male patient with normal habits who presented to us with sudden severe headache of 1 month duration and worst at onset, which required a hospital visit. Subsequently, it became episodic with decreased intensity and without any history of trauma or black thinners. On neurological examination, there was no neurological deficit. The fundus was normal and no cerebellar signs were present, and with no meningeal irritation signs, and motor system, sensory and reflexes were normal. So coming back again to the... Yes.
Any neurology or medicine residents here? I'm sorry to say, but one of the purposes of CCR is resident education. And I don't find the residents neuro, not neurosurgery, neurology. Yeah, so my request is that from the next CCR, the related departments, Dr. Munish always announces the CCR topic in advance. The related departments have to ensure that their residents are present, because the presenting department may know the entire case, but the related departments and those residents, the exam going residents, should sit, as I said earlier, on the 3rd, 4th and 5th benches there. And they have to answer these questions, otherwise it becomes a one-way presentation. Now please highlight, headache is such a common problem.
Yes.
What are the alarm signals here which make it different from a usual headache? That is what the medicine and neurology residents have to know.
Yes, sir. So if the patient is having a sudden headache, sudden in onset, very severe in intensity, sir, and it is the patient specifically complains that it is maximum at the time of onset, or a thunderclap type of a headache. That is, he also, sometimes the patient comes and complains that he had the worst headache of his life, sir. So these are the alarming symptoms associated with nausea, vomiting. He could have blurring of vision, sir. So these are signs of raised ICP which one should consider as if the patient is having headache, sir. No, sir, but,
sudden severe headache.
Yes.
Hemorrhage.
Yes, hemorrhage. Yes, sir.
Only alarm is sudden and acute.
Sudden and acute onset. Yes, sir. So coming back to the possibilities, we need to exclude the causes. So why not migraine? For migraine, the diagnostic criteria are the patient should have at least more than 5 attacks. The pain should last for 4 to 72 hours. And the patient should have at least 2 of the following things, like the patient should have a unilateral or a pulsatile headache, moderate to severe in intensity, and it should aggravate by daily routine activities like walking, eating, anything. And one of the following things that is the signs of aura which we say, that is nausea or vomiting associated with photophobia or phonophobia should be there. And it should not be explained by any other criteria of ICHD, that is International Classification of Headache Disorder. So this is why we rule out migraine. Why not cluster headache? Cluster headaches are generally very severe to very severe. They are unilateral, severe orbital pain is there, temporal pain is there, or supraorbital pain should be associated with there. Plus one of the following things should be there in case of cluster headache. That is, either the patient should have ptosis, meiosis, congestion, rhinorrhea, fullness, eyelid edema, fullness of ear, eyelid edema, and redness of eyes or lacrimation should be there. Autonomic symptoms should be there, sir. And the patient is so restless and anxious that he has to walk, he cannot sit at one place. So this is a very classic thing about cluster headache, and the patient can get at least 1 to 8 episodes of headache like this in a day. So coming to tension headache, why it is not a tension headache? The patient should have at least more than 10 episodes. Along with that, the pain lasts for 30 minutes to 7 days, And along with that, two of the following things should be there. The patient has a bilateral headache. He specifically complains that there is a band which is tied over his head, and it is a non-pulsatile type of headache. It should be mild to moderate and not aggravated by any other factor. And it is generally not associated with nausea and vomiting. And one of the things like photophobia and phonophobia should be there, but both cannot be there together.
Can you explain what is that type of headache which occurs when the plane suddenly comes down or goes up, and then there is a severe pain in the head?
Sorry, sir. I don't know, sir.
It is often seen when the plane descends very quickly,
Yes, sir.
right, loses altitude.
Yes,
There
sir.
is a severe headache, usually in the frontal areas, sinuses and all those things.
Yes, sir.
So, can you explain, or anybody can explain that?
Sorry, sir. I don't know, sir. Sir, vascular so coming back to the case, sir, vascular cause could be one cause, sir, we can consider, because really it is worst at the time of onset, and this is the specific complaint which the patient gave. Why not pituitary apoplexy in intracranial space occupying lesion? Generally the patient complains of severe headache with sudden vision deterioration, that is he loses his vision. So pituitary apoplexy is less likely, sir. And why not colloid cyst? Colloid cyst is generally a positional headache, sir. The patient complains of that in a certain while sitting, he gets severe headache, and sometimes it is associated with a very specific feature of it, which is called as drop attacks. The patient suddenly falls, but he is aware of his belongings and surroundings. So this seems a very unlikely thing, sir. Why not infection? There is no sign of any fever, there is no nuchal rigidity, and no constitutional symptoms, so fever seems unlikely, sir. Why not glaucoma? Glaucoma, the patient generally complains of a retroorbital pain with redness and sudden vision loss, sir. Painful vision loss is there in acute angle closure glaucomas, so it seems unlikely, sir. Coming to exertional coital and cuff headache, generally if our patient is not giving any complaint that on exertion or coitus or on cuff, his pain is aggravating, sir. Headache is aggravating, so this seems very unlikely, but such headaches can be due to any aneurysm which has ruptured during such activities. So these things can lead to headache, sir. So coming to vascular cause, subarachnoid hemorrhage, spontaneous bleed, and cerebrovenous spinal thrombosis are likely causes. So in order to confirm, we need to further investigate these patients. So we got a routine blood investigation done. The complete blood count was normal, including ESR. Serum electrolyte, that is sodium, potassium and chloride, were within normal limits. Renal function test was normal. Liver function test was normal, including the thyroid profile was normal. Calcium, phosphorus and coagulation profile was also within normal limits. So we further wanted to investigate the patient to know the cause. So now I would request Dr. Subhash from Radio Diagnosis Department to come and tell about the MRI part.
Good morning, respected teachers and my dear colleagues. I am Dr. Subhash and I will be discussing MRI finding of this patient. There were 2 MRI done outside and we had limited images, and the pictures are taken from MRI films. So the quality of the images is suboptimal. Of our patient, T2 flare, hyperintensity, collections along the right cerebral convexity and also along the left posterior falx cerebri, which is showing extension along the tentorium cerebelli with no significant abnormality. On the right side, the image we can see a hypointense collection suggestive of hemorrhagic content. There is also a midline shift towards the contralateral side. Overall, these findings are suggestive of subdural hematoma. This is the second scan of the patient after 1 month. We can see there is an evidence of a subdural collection along the right cerebral convexity, which has showing the mixed signal, both dark and bright signal, both T1 and T2 images. The hypointense signals on the T2 image represent acute component of the hemorrhage, while the hyperintense signal on the T1 and T2 images represent the late subacute component. and there is effacement of underlying sulcal spaces and Sylvian fissure with midline shift to the contralateral side. These findings are suggestive of acute or late subacute subdural hematoma with mass effect. Now I would like to call Dr. Anurag.
Can the urology team please explain or tell us which patients with headache should go for MRI? Because not everybody who has a headache will or should have MRI. So what are the indications when you advise an MRI?
So patients with any red flag signs with neurofocal deficits or seizures along with headaches to evaluate the cause. And so in cases, if it's an acute onset with thunderclap headache, first we'll go for a CT scan, sir, and then to evaluate further we can go for MRI later.
We also divided the primary and secondary headache. Primary headache, we don't need this further investigation according to history and clinical examination. But in history and examination is suggestive of any red flag, that is including the headache that is a thunderclap in nature. Second, headache that is associated with systemic features like fever, weight loss, other constitutional symptoms, or headache that is having focal deficit, means focal signs. So these are the indication to have some underlying cause of headache. So if we are thinking a patient could have the secondary cause of headache, then we need the further investigation. Normally imaging is indicated. CT is means a first choice if we are suspecting SAH, but if we are having MRI and headache is of a subacute to chronic in onset, MRI would be the better choice, especially to rule out the IIH or intracranial hypotension syndrome.
This particular patient, what was the indication for MRI?
Actually, this case initially had thunderclap headache that was quite severe in onset, and that was acute in onset. Before that, he doesn't have any history of prior headache. That is per se is the red flag. Patient first time having severe thunderclap headache, and after that patient is having persistent headache. That is the indication of to have the imaging. The course is the subacute to chronic one, so we ask for the MRI rather than the CT.
So on basis of history, clinical examination and radiology, we came to a diagnosis of right frontotemporoparietal acute and chronic subdural hematoma. So in view of our diagnosis of right frontotemporoparietal acute and chronic hematoma, plus there was increase in thickness of hematoma and midline shift compared to the last 1 month back cancer. So some intervention was definitely warranted for this patient. So the treatment modalities consist of surgical, endovascular and hybrid approach. Hybrid consists of both surgical plus endovascular approach. So the treatment protocol for chronic SDH is if the midline shift is less than 5 mm and the thickness is less than 10 mm, then generally we go for a conservative management. But if there is slight increase on a follow-up scan, then we can think about middle meningeal artery embolization if the patient is clinically okay. If the midline shift is more than 5 mm thickness and more than 5 mm midline shift is there and more than 10 mm thickness is there, then we have to assess age and risk factor for the patient. If the patient is a high risk candidate, more than 70 years with many comorbidities and on blood thinners, then we do a MMA embolization if he is clinically okay. And we can go ahead if we want, we can do a subdural evacuating port system. If the patient is a low surgical risk patient, less than 70 years of age and fewer comorbidities, both the option can be given to the patient that he would require a burr hole or a craniotomy or a middle meningeal artery embolization, explaining the risk that there is a chance of recurrence in case of embolization. If the patient comes with a rapidly worsening GCS, then straight away we have to take him to operating room, and depending if he requires a burr hole or a craniotomy. Craniotomy is basically done if membranes are there. So our patient fits into the criteria of more than 5 mm midline shift and thickness, 10 mm thickness. He is low risk surgical candidate. So both the options were given to the patient. So after discussion within the department and also with neurology and radiology department, both the options of surgery and endovascular management were given to the patients, and he opted for endovascular management. So a middle meningeal artery embolization was planned after explaining the risk of recurrence. So now I would like Dr. Yogesh to come and explain. Yes, sir.
Like in a patient like this in which there was no,
immediate medical or surgical emergency, would you not like to know and find out and investigate the cause of why should a young man, 27 years old, no head trauma, no anticoagulants, why should he develop hemorrhage?
Yes,
60, 65, 70 years, yes, trivial trauma, hematoma, but a young man, 27 years old.
Sir,
To the question,
yes.
would you not like to evaluate the intracranial vessels? That has not been done as yet.
Sir, generally it is considered if SDH is there, then it is due to either the sharing of these large draining veins which are there, sir. And sir, sometimes it could be spontaneous, sir. Not always there is a cause, and we have seen, sir, patients coming at young age, young patients also, sir. So,
like intensive investigation.
sir, it is generally not very much warranted.
Definitely in a young patient you have to be evaluated, especially dural AB. Sometimes dural AB fistula can have some unusual presentation, and sometimes patient with coagulopathy, those we can't pick up on the routine investigation. We sometimes need the von-Willebrand factor deficiency, and we can have some subtle manifestation of the hemophilia that we can't pick on the routine investigations. We need the extensive evaluation, but definitely in the certain population of patients we could not find out any cause. Especially in the Indian scenario, in neurosurgery department, we have a lot of patients, and after the extensive evaluation we couldn't find. But in particular case, we got the imaging on the cerebral DSA, but he was related for this coagulopathy, but unfortunately we couldn't get any specific cause.
So if this patient has an intracranial bleed,
Yes.
then your focus would shift towards an EVM or
Yes, sir. Aneurysm. Yes, sir, definitely.
just because it is extradural,
It is subdural, sir. Plus location also depends on the bleed, sir. If it is filling the cisterns, then we can think of an aneurysm, sir. So now I would like to hand over to Dr. Yogesh to discuss about the endovascular management part.
Good morning to respected teachers and my fellow colleagues. I am here to describe the endovascular management of this patient. So before we start, a couple of slides about her department. So this is the angio suite, which is located on the second floor. We are using this cath lab along with cardiology and interventional radiology. And for interventional neurology, it is headed by Dr. Gaurav Goyal, sir. These are some stats from last few years. In the 2023, we did 140 DSAs, both cerebral and spinal, and we did more than 100 neuro interventions. What procedures we are doing? We are doing intracranial aneurysm coiling, stenting, which is coiling that is assisted by stent or balloon. We are also implanting flow diverters, which are quite costly. We are doing AVM embolization, stentings, mechanical thrombectomies, tumor embolization, intra-arterial vasodilatation therapy in cases of vasospasm. So coming back to the case, before I tell about how we did it, I'll tell about the course of the middle meningeal artery. So this you can see, this is the arch of aorta, and this is the right brachiocephalic trunk, which divided into right common carotid and subclavian, which further gives the vertebral artery. This is the left common carotid artery, and on the other side you can see the left subclavian, which is giving the vertebral artery. So this is the lateral view, in which we can see this is the right common carotid, which is divided into ICA, internal carotid artery, and external carotid artery at the level of C4, and the one anteriorly is the ECA, and this is the superior thyroid branch, this is the lingual branch, the facial branch, and then the terminal branches, the maxillary artery and superficial temporal artery. Also we can see the posterior occipital artery, which is a branch of ECA. Then we further we see the end branches. This is the maxillary artery, and from the first part, the maxillary artery is divided into three parts by the lateral pterygoid muscle, and from the first part we can see the middle meningeal artery. So on DSA, when we visualize on subtraction angiography, the first branch will be the middle meningeal artery, because the other two branches are not visualized. Then this middle meningeal artery enters the skull through the foramen spinosum and run along the skull bones, invaginates and run along the skull bones and supplies the dura and skull bone. This is the picture of how it supplies, between the layers of the dura, it supplies the dura, and these are the cortical vessels, veins and arteries. This is the dural venous sinus. Then how we approach the middle meningeal artery embolization? We do it under general anesthesia. We require complete sedation and paralysis, and we access through the right femoral puncture under the cover of heparin, and we use various catheter sheaths and wires. This is the video, animated video, how we puncture the femoral artery, and after that we put a sheath over the wire, and through the sheath we take various wires and catheters and approach the arch of aorta, and from arch of aorta wherever we want to go, as in right side, left side, vertebral artery, we can go there. So in our case, we from right brachiocephalic trunk we approach the right common carotid, and we took a shoot using the omnipic dye, and here you can see the bifurcation of the common carotid artery. This is the ICA, this is the ECA with along with various branches. After this we approached the right external carotid artery. This is the video, and the shoot is taken at a higher level, so we can see few branches. This is the facial artery, this is the maxillary artery, and the first branch of the maxillary artery on a visualization is the middle meningeal artery, this one. See, this is originating, there is some overlap, but it is originating from here. And this is the terminal branch, superficial temporal artery. So after this we use micro wire over micro catheter, and we are approaching the middle meningeal artery. And now we have taken a selective shoot of the middle meningeal artery. These are the branches of middle meningeal artery. This is the frontal and this is the parietal branch. So after this we place the catheter, micro catheter, marathon, and we embolized using squid 12. So this squid 12 is a ethylene vinyl alcohol copolymer, and before this we inject a solvent that is called as DMSO. The squid 12 is basically liquid form outside, but once we inject after DMSO, it solidifies in the required space. So after this we can see the next video. In this there is no filling of the middle meningeal artery. So on comparison, pre-embolization, this is the middle meningeal artery, and post-embolization there is no filling of the middle meningeal artery. So after this the patient was in observation for 6 to 12 hours usually, and our patient was hemodynamically stable. There was no deficit, all the peripheral pulses were present, and he was asked to follow up after 1 month. And what challenges we faced in such cases is, one of the challenges runoff of the embolic agent. So if there is a sudden rise in pressure during operation, this squid 12 can run off and embolize somewhere else where we don't want. And it is a very rarely done procedure, and it's first in Rajasthan. So now after this I hand over the presentation to Dr. Anurag to tell about follow-up and further.
You have localized that there is a hematoma and this is an area supplied by the MMA.
Yes, sir.
But when you did the angiogram, no active leak was found, and
yes,
no
sir.
abnormality like an aneurysm or some structural abnormality to say that this was the diseased vessel. So you have empirically embolized the middle meningeal artery on inference.
Yes, sir. The newer pathogenesis what we are is being given is, this SDH is caused by some trivial trauma, and then there is a rupture of the dura cells, and after that there is some bleeding, and it causes inflammation, exudates formation, and this exudate formation causes neovascularization, and these new vessels, they are very sinusoidal, and they form collaterals with the middle meningeal artery. They are very small, not visualized on DSA. And if we embolize the middle meningeal artery, we are treating the basic cause of this channel formation.
You can see the prior DSA images just before that, and before that, show the shoot of this middle meningeal artery. Here you can see on the distal parted there is some dilatation of vessels. Actually in chronic SDS there is the new angiogenesis and the formation of the small vessels along with the dura mater, and that forming the pseudomembrane. And because of the pseudomembrane, there is a persistent secretion of serous materials. That is the basic pathophysiology. Even surgical intervention performed, like burr-hole, there is a high chance of recurrence. So sometimes what neurosurgeon they do the total hemicanectomy and removal of that membrane. And that is the alternate of that procedure. Here, we causing the devascularization of that membrane. Here you can see that the distal vessels are quite prominent. Middle meningeal artery is not disease.
there is a disease in the membrane. There is a pseudomembrane formation is there, and because of this neoangiogenesis, there is a secretory material, and that causing the persistent formation of that material that accumulate. That's the reason patient is a high chance of recurrence despite of the evacuation. And our aim to devascularize that membrane. And here we can see there is a normal middle meningeal artery, but distally you can see there is a subtle hyperintensity are there of the contrast. That per se suggests that there is neoangiogenesis is ongoing.
Can the intracranial vessels be approached by the radial artery route?
Nowadays, most of them is few centers in the India, even abroad, they are trying to do this radial one, but still radial means going through the radial, then the subclavian artery and approaching to the common carotid, we need the different type of catheter, and procedure sometimes take a long time. So now people are trying, but routinely still be performed with the transfemoral. In selected cases, like patient is having peripheral vascular disease, having involvement of femoral artery, so we can't approach. In that cases, we usually perform the transradial, but still our approach is the transfemoral to reduce the procedural time. Okay, we need the more time in the radial, almost 1.5 times. Radial now is the standard of care in the cardiology, and neurology subcenters, few centers they are trying, but still time is more required. So in after a few decades, probably we may opt this one, and especially the availability of the new catheters.
So I have a question also.
We did that one. वो दिखा दो. इसमें we take the actually before performing middle meningeal artery embolization, we usually perform the thorough cerebral DSA to rule out some underlying intracranial vascular abnormality.
So the DSA was done, but I have not included in the presentation for time purpose. Yes, sir, it was normal. All 6 vessels were catheterized and shoots were taken.
So I have a question also. Your middle meningeal artery embolization will prevent further bleed. What about the blood which is already collected, the hematoma which is already there? That is what is producing the mass effect, no? Does that not need to be evacuated?
Sir, it by time, sir, over time it absorbs on its own, sir. Because so we are just...
your indications for surgery is that midline shift, no? And the consequences of the midline shift. So is that not an emergency to address?
But actually we can wait, sir, if we are addressed the main cause, sir.
Show the protocol.
Yes, sir. If we have addressed the cause, sir, we can actually wait and observe the patient over time, sir. This we can either, sir, this is the whole crux of it, sir. If sir. Surgery, if the patient is rapidly worsening, sir, then we need to operate, sir. If we can still keep the patient under observation, sir, after this, and we can wait, we can get a scan after 1 month done and look for a repeat scan. If there is an increase, then we advise him surgeries.
This question is very pertinent.
Yes, sir.
He had midline shift.
Yes.
Why did you not do surgery? Because he had multiple locules.
Multiple locules, yes, sir. Membranes are there, sir.
Locules.
So there is formation of membranes, sir.
Different age of hematoma. Fluid is there, clot is there, then membrane is there. So in this, what maximum you can do is by burr hole you can just remove fluid only. Yeah. But patient was not that much symptomatic. So nowadays it's well accepted. But usually it is an adjunct to surgery.
Yes.
If there is a great midline shift, you do burr hole and then you do this also. So recurrence is
now we follow the multidisciplinary approach.
And usually patient अगर किसी दूसरे center में होता तो probably they could have done this burr hole, but now we are in a multidisciplinary approach with discussion with Sharma sir and Pankaj sir, and then we decided for that.
So, sir, on follow-up, the post-procedure next day, the patient was discharged. On 3 months of follow-up, his headache had significantly reduced, and he used to consume only 2 painkillers per month now, and repeat scan showed a very thin hematoma. And on 6 months of follow-up, the patient was completely asymptomatic with complete resolution, as we can see in these MRIs. So here I conclude this case. In almost all the centers, chronic SDH is managed by surgery, but in case, after thorough discussion, we manage the case by a fairly new minimal invasive technique, sir.
Before we go on to the review of literature and other things, one basic question for most of our residents and other faculty members.
Yes, sir.
When you are doing a CT scan of the brain and you are doing an MRI, what is the difference and what is the different things that you get from those two things? A basic question.
Sir, if
the radiologist will
if a patient comes in a very acute pain, severe pain, then first investigation of choice is CT scan, sir. we never go for an MRI. First of all, it takes a lot of time, sir. It takes around 45 minutes. CT scan is easily available, and we get to know if there is any bleed or not. So we can address that, and we can get further investigation, or we can start the treatment, sir.
Not just in this patient of a
Yes,
severe
sir.
headache.
Yes, sir.
When you are doing a brain CT and you're doing a brain MRI, what are the different things that you get from the two procedures?
Sir, okay.
Actually, if patient is having acute headache and present in the emergency, CT is the first choice. Our main concern is the SAH, subarachnoid hemorrhage. And if patient present in the OPD, especially in the subacute to chronic case, especially in these cases, we have to rule out the idiopathic intracranial hypotension or idiopathic intracranial hypertension or some other causes like CBST. In especially subacute to chronic cases, we may miss the diagnosis in the CT. In these cases, MRI is the first choice. If patient present in the OPD with acute onset of headache of 1 or 2 days, so still we can get the CT. So we have to think of the type of the headache and the duration of headache. Then according to that, we will decide the neuroimaging of choice. Sometimes what happen, we ask the patient to get the CT, but after getting normal CT, we ask them for MRI. So patient attendant get annoyed कि भाई डॉक्टर साहब तो पहली बार में एक ही चीज करानी थी. Why you are asking of two things? So we have to think for that. क्योंकि स्पेशली अटेंडेंट होते हैं तो स्पेशली इन आवर सोसाइटी दे गिव द वन विंडो टू गेट द इन्वेस्टिगेशन. वी कांट आस्क कि आपने अभी CT करा लो फिर MRI के लिए बोल रहे हो. तो वी हैव टू डिसाइड अकॉर्डिंग द टाइप ऑफ प्रेजेंटेशन एंड द ड्यूरेशन ऑफ हेडेक. Definitely contrast MRI would be the better one, and especially patient presented in an altered sensory emergency and we are suspecting metastasis, still CT would be better one. If we need the urgent surgical intervention like decompression or removal of this mass region.
So coming to the review of literature, chronic SDH is a growing problem. It is more common in older people, and by demographic studies it has been seen by 2030 it is going to be the most common cranial surgical condition. It is 3 times more common in adults more than 80 years. The reason being age-related brain atrophy, risk for falls, use of blood thinners, and alcohol intake, sir. Earlier it was believed that large bridging veins were the cause, the large blue bridging veins were the cause, but the new theory is injury to the dural border cells are the cause of bleed. So dura has 3 layers, the periosteal layer, the meningeal layer, and the dural layer. These dural layers are basically formed by modified connective tissue, and this is the chronic subdural hematoma cycle. So any injury or sometimes spontaneously also, these dural border cells splits open, and again the process of inflammation starts, that is angiogenesis, exudation and hematoma formation, and it continues over time and it leads to expansion of hematoma. The patient might present with headache, nausea, vomiting, confusion, seizure and weakness on one side. And on CT scan you can see the different types of SDH. Acute SDH looks like a crescentric hyperdense mass and subacute SDH looks like a isodense mass and lesion, and chronic SDH looks like a hypodense to isodense lesion. Surgical management includes twist drill craniostomy, which is done bedside in an emergency cases. Burhole is another modality. Actually, burhole surgeries were done around 7,000 to 10,000 years old back, and these are the most ancient surgeries ever. And the most conventional method done by surgeons is craniotomy and removal of hematoma and membranectomy. These are the surgical advances like subdural evacuating port system, sir. These are new gadget, and endoscope assistance is also being used after doing a small craniotomy so that we can remove the membranes better. So in our institute we almost operate one chronic SDH every other day, sir. So we operated around 181 cases of chronic SDH in last 1 year, 130 through burholes and 51 through craniotomy, but we got just 1 recurrence, which is far more better than most of the institute studies.
Good morning all. The lesson learned from our case is that a simple headache can be a manifestation of underlying serious disorder, and specifically if this happens first in middle age group and older age group. The selection of treatment modality is the key in management, and the surgery remains still the gold standard treatment in the large number of cases of chronic subdural. Middle meningeal artery embolization shows much promise as a treatment because it addresses the main etiological factor of the genesis of chronic subdural. And the take-home message is that embolization of middle meningeal artery for the treatment of chronic subdural is a path less traveled so far, and the careful case selection based on radiological findings, clinical profile and the presenting symptoms of the patients are mandatory. The multidisciplinary approach for management of such cases is required. And the good news that last CCR, which was done on August 23, lateral sacral artery aneurysm by the Department of Neurosurgery, is published as a case report in the Journal of Neurosciences in Rural Practice. And in the last, I would like to thanks from the on behalf of Department of Neurosurgery to MGMST Management, Department of Neurology, and Department of Neuroanesthesia and Radiodiagnosis, and the special mentions and thanks to CCR committee.